Hello, everyone. It is a big pleasure to be here talking to you in World Schema Therapy Day. I'm Leonardo Wainer. I'm a former EB member of the ISST, and I'm really delighted to know that the initiative that we started when I was also part of the EB has continued and has grown so much. So I want to first give props to the former EB and the current EB that is really doing an amazing work to spread schema therapy and really to enrich the model that we all love and that we all are really keen on. So I'm going to share my screen with you, and then we'll start talking a little bit about my presentation today. So today I'm talking about the state of evidence in schema therapy, and also I'll be discussing a little bit about the future paths for the approach. As I said, I'm Leonardo Wainer. I'm based in Brazil. So it is a pleasure to be talking to everyone all around the world in every single continent that we are part of. And this is my social media and also my email. So if you want to discuss about any of the articles and the research that I'll be speaking, please reach out to me and I'll be delighted, honestly, to talk to you and to communicate and have a correspondence with you because I think that really to have this conversation about evidence-based practices and schema therapy is such a big role on what we want to do as a society that really is pushing schema therapy forward. So, just to introduce myself, I'm a psychologist here in Brazil. I have a master's degree in clinical psychology, and I am finishing my PhD fellow at the Pontifícia Universidade Católica do Rio Grande do Sul. I'm also an advanced level schema therapist. My training was with Wendy and Jeff in New York. I'm also a trainer and supervisor certified by the ISST. I'm a former ISST Executive Board Member. One of the directors of Weiner Psychology, the only training institute that is certified by the ISST in Brazil. I'm also a specialist in cognitive behavioral therapy here in Brazil, and I'm the science coordinator for the Brazilian Association of Schema Therapy at the moment. I also like to say that one of the things that really pushed me when talking about schema therapy and talking about psychotherapy as a whole is the understanding that it is a science. So we can really measure what we do as clinicians. And it is really important that we do that. Once we do that, once we know what we are actually doing, we'll be able to help our clients way more effective in a way more effective way. So this is really the reason for my presentation today, to really understand what we know about schema therapy at the moment and what do we need to research more moving forward, because that's also really important for us. So to start things off, I really love this quote by Carl Sagan. I'm a huge physics enthusiast and I love science as a whole, but physics is something that if I wasn't a psychologist, probably I would study physics. So I love what Carl Sagan says here, that we can judge our progress by the courage of our questions and the depth of our answers, our willingness to embrace what is true rather than what feels good. Uh, what Dr. Sagan here is talking is actually I know that if you are watching this presentation, you probably really love schema therapy as I do. But it is not a model that is for everyone. It is not a model that it is for every single situation in our clinical practice. And we should be able to ask these tough questions and really see what are we doing as schema therapists? What are we researching? And are we actually, do we actually have the evidence to back up some of the techniques and some of the stance that we take? So this is what Dr. Sagan is actually asking about. Not really about schema therapy, but as a science as a whole. So the agenda for today is, why should we care about the current state of evidence in schema therapy? So that's the question that I want to answer with you guys. Also, to go through the current state of evidence in schema therapy. So we'll go a little bit about the main disorders that we do have evidence for, and we'll talk about what the evidence is right now. We'll also talk about some future agenda of research for the approach. So what should we look for in terms of research? And this will also be backed by the Delphi that was published a couple of years ago by Pam Pinkton, Rita Union, and Jerry Karentzes. And also I'll be pointing out some points of attention to clinicians and also to us as a schema therapy society, because we need to be coherent with the evidence. We need to be coherent also with the model. So I know that there's a push to improve, to enrich, and even to update, but the push for progress without the care for the evidence as a whole can be detrimental to what we have already built. So I'll be pointing out a couple of things that we should be taking into account when we are understanding the research that we actually have and what a new article actually means for a theory and for the model as a whole. So to start, a starting point that is actually important is that not all evidence is of the same quality. So we can have 2 or 3 different articles, papers that have been published, but they mostly don't have the same quality at the same time. All evidence has limitations. Even the best randomized controlled trials, even the best meta-analysis, all of those studies, they do have some limitations. And this is what research is about. When we go through the limitations to understand what we need to study and what we might be not really being able to respond with the research, with the results that we obtain from that study. So not all evidence is of the same quality. So a case study is not the same as a randomized controlled trial. I know that you do know that, but it's important for us to point it out, because at times we can look at one randomized controlled trial and think that that's enough evidence to say that we do have evidence. But like I just said in the other sentence here, it's not enough to have evidence. We need evidence of quality. So we need a number of studies, and we need evidence that has a high degree of quality, and that can be really tough in psychology and social sciences as a whole. But this is something that we should strive for. It's not that we want to bash any study that was published. Not at all. All of those studies, they add up and they build this evidence that we have, this body of evidence that we do have already for schema therapy, and we need to build on that. So it's like building muscle. You go to the gym, and then you start hitting the weight room, and then you grow a little bit of your muscles. Do we want to say that that's not enough? No, that's good. But we can see what we have already built, and we can build on top of that. So why should we care about the evidence in clinical practice? To put it simply, the goal of psychotherapists as a whole should be the clinical improvement of patients. So our goal is not to promote a model. Our goal is to improve the life of our patients, is to help someone that is in need, that goes to therapy, and we want to assist that person to improve on what they actually need. So that implies that it implies the clinician's responsibility to make decisions that are in the best interest of the patients. So that leads us to some of the bioethical principles of health. The first one, that is autonomy. So the client has the autonomy to decide what they want to do with their own treatment as well. So if they do have this autonomy, what do we need to do as a clinicians? We need to inform. We need to inform what we are doing, what is the evidence that we have for that model, for that psychotherapy, for that treatment. Justice, we need to strive for justice and the justice of our clinicians and of our patients and of mental health as a whole. The beneficence, so we should strive to do good. And this is something that we need to be aware of, because in the strive to do something good, we need to be aware of not the maleficence. So to not do something that is actually harmful for our patients. So we need to have those bioethical principles in mind once we are understanding how we want to approach a client that is arriving to our clinical practice and is talking about a lot of the things that is actually making their life hard. And then we need to take those principles into account in order to make the decision about what clinical and therapeutical road we're going to take. So theoretical models are like CBT, Schema Therapy, ACT, DBT, and whatnot. They are a set of constructions that is used to explain and interpret human phenomena. I have a professor on my PhD that he loves to say that uh, nobody owns human suffering. It is just a phenomena. So we interpret those phenomena with cognitive models that understand that. So a schema, we created the schemas in a way, because the schemas have always existed, but Jeff was the one that was able to construct and conceptualize what it was. So it is a theoretical model that aids us to explain the functioning of personality and psychopathology as a whole. And then we can ask ourselves, are these theoretical models absolute truths or different perspectives? Because if we take a look about different models of psychotherapies as a whole, we can see that in different models, we explain very similar processes with different names. So we should be able to understand that we cannot say that those are absolute truths, but they are ways of explaining a phenomenon. And then we can use science to validate those models through empirical testing. So I can say that a schema is something that is raised like really like a little voice that is inside of our minds. Okay, so we can test that through a lot of empirical testing and see if that works or not. So theoretical models, there are tons, but not all of them have been backing up by the empirical testing. And this is something that we as clinicians should be aware of. So besides that, there are specific factors for each psychotherapy approach, because there are common factors like the therapy relationship. Every single psychotherapy has a therapeutic relationship and therapeutic alliance, but there are some specific factors, and we can think about it in schema therapy as a whole. So the specific factors are the technical procedures that we use to obtain results. So it is we focus on the clinical targets, the complaints and demands of our clients. We have a theoretical explanation for the origin of the problem. So let's assume that we're talking about a BPD client that has an abandonment schema, and that schema is getting triggered when the need of safety and attachment is not being met by their partner. So we have a theoretical explanation about why that feeling of abandonment and the feeling of void pops up in our client. So we can then think about what are the mechanisms of change that are consistent with the theory. So we can talk about the limited reparenting, we can talk about the imagery work that we would use. So that is a specific technique. This is a specific technical procedure that we would use to talk and to focus on that theoretical uh, explanation that is actually organizing that issue. So also those technical procedures, they explain how the functioning of the demand direct to specific interventions. So we can use the case conceptualization to understand the functioning of our clients, and then that will lead us to some specific intervention. But how do we know what we have to do? Actually, is through research that we know what we have to do in each specific time. So that's why we have protocols for our CTs, for example. So we have a protocol. Of course, it can be a little bit individualized for our clients, but we have a template of what we should do for each situation. And the results then can be attributed to specific therapeutic intervention. So if we have a client that, like we just said, that has BPD and has a schema, an abandonment schema that is activated, if we do the limited repairment, if we do the imagery, then we can see the decrease on the severity of activation of that schema. Then we can attribute that result to those techniques that we used. And then why should we care about those evidence? Because we really want to strive for schema therapy to be a really strong evidence-based practice in psychotherapy. Uh, we need to understand that evidence-based practice in psychology and in medicine or whatever, it is actually the individualized clinical decision-making process that occurs through the integration of the best available evidence with clinical expertise in the context of the patient characteristics, culture, and preferences. So, for every demand and every client that pops up in our consulting room, we'll need to understand what are the best available evidence for that specific issue. And then we'll need to go back and look inwards and understand, do we have the clinical expertise? Do we actually know how to apply that treatment? And is that evidence actually connected? And does that make sense within the context of the patient? Does that make sense with their characteristics, their culture, and their preferences? And if any of those questions is no, then we will need to go back and really take a look on that evidence and see different ways that we could approach it. So, therefore, being aware of the available evidence allows the clinician to make the best possible decisions to address the client's needs. Our goal then to here, at least my goal here with you guys, to talk about the evidence that we do have in schema therapy is for you guys to be aware of where we actually are and then how we can see our clients' issues and see if schema therapy is actually the best possible decision to address that specific problem that the client is bringing to us. But then our little friend here asks us, uh, but is every instance of clinical improvement truly synonymous with effectiveness? Because you can reply to me after this. You could reply to me after this presentation and say, "But Leo, I do use schema therapy for for agoraphobia. And we do not have really good evidence for that at the moment. And we do actually have other treatments that have better evidence for it. Uh, and then I can say that it could be effective. It could also actually be a really good treatment option, but we do not know it for sure due to the evidence that we do have. But I would also say that there might be a little bit of there might be different reasons for why the client improved. And we need to understand that clinical improvement does not necessarily mean that an intervention is effective. There are what we call confounders that can make it difficult to understand those results. And confounders are the factors that change, they alter the clinical outcome that goes beyond treatment. So there are a lot of things that happen in the week of our client, during the duration of our client's treatment that goes beyond what we actually are treating. And we as clinicians should be really aware of it. Because if we don't take into account that a confounder might be a factor that is uh, taking the part of our client's process, we might be lacking the understanding of what is actually going on in that therapeutic process. So there are some confounders, and I'll talk a little bit about a couple of them here. You can take a look at this chart by Fletcher and et al. And they'll say about the improvement in clinical psychotherapy, and then there'll be the natural history, the Hawthorne affair, the usual care, placebo effect, and intervention. So there are a lot of confounders. I won't take the time. We could take like a whole day to talk about confounders and clinical improvement as a whole. Actually, I do have a paper that is written about it. It is in Portuguese, unfortunately, but myself and some other colleagues, we discuss about all those confounders. So we know that there are some uh, instances, there are some psychopathologies that time alone can have an impact on the symptom reduction. And then the clinician is like, oh no, my treatment is working so well. My patients are improving really, really well. But actually, it might not be caused from the intervention. It could be just by time, by regression to the mean, the usage of other interventions by the patient. So the patient is now doing therapy, and now they want to sleep a little bit better, so they change a little bit about their lifestyle, and then they improve. And also there's the Hawthorne effect, that is the fact that people change the way that they act when they know that they are being evaluated. And we have to be honest here. Therapy is about evaluation. So someone knows that they are being assessed, they can change the way they act. And by doing that, the individual can actually have an improvement in their condition as well. So we should be aware of those confounders. And this is just an idea. Like, so a lot of times people think that intervention leads to outcome, but we need to understand that intervention can be affected both ways by the confounder, and then it would lead to outcome. So we need to be aware that that relationship can also exist. And all of this to say that we really have to be mindful about what the intervention that we are using is for. So we need to be mindful, like, why am I using imagery here? And as a supervisor, I need to tell you guys that a lot of times when I'm assisting another clinician in supervision, when I'm giving supervision to a supervisee, they are using at times an imagery, and then I ask them, "Why are you using that?" "Oh, because I'm supposed to." But actually, we should be aware. We should be we shouldn't actually answer in that way. We might actually be aiming to answer that I'm doing that because the conceptualization leads me to that. And by doing an imagery here, I'll be able to limit to reparent my patient in their with their need of attachment, which will assist on the decrease of the activation of the abandonment schema. So actually, we need to be aware of why we are using such and such technique. Then, if we are able now to understand why the evidence is important, we are now able to look what is the scope of evidence that we have so far as an approach. And then we need to talk a little bit about the schema therapy landscape. So there are actually this paper by Pam Pilkington, Rita Union, and Jerry Carantas was actually, I would say that the main reason that I wanted to talk about uh, the the current state of evidence in schema therapy because I played a role in this paper. I was in the EB at the time, and then Pam and Jerry they interviewed us to understand what we thought that was important for the landscape of research in schema therapy. And there are a lot of priorities that we should be aware of and that we actually do need to study in schema therapy. And last year, my father, who is also uh, he was the national coordinator of certification for a long time in Brazil. Now I am that person, but we actually wrote a chapter about the evidence of effectiveness in schema therapy for a book here, and then we were able to actually take a deeper look on what we do have so far. So we know that schema therapy is an integrative psychotherapeutic model that was developed by Jeff Young as an extension of CBT. And schema therapy was initially designed to treat individuals with chronic treatment resistant conditions and personality disorders. And we know that that was what Jeff used to do, was the aim that Jeff had at first. But we know that the model has since been applied to a broader range of clinical populations. And we know that because there are a lot of people that do supervisions, and when we go to the ISST conference, we are talking about trauma, we are talking about eating disorders. So we know that there are a lot of um, ways of applying schema therapy, but we actually should also answer like, do we have the evidence to back that up? And if we don't, this is not like a lost situation. No, it is just like, okay, so there are people that are experimenting with that. We should research that and confirm if that is true or if it's an anecdotal uh, evidence. So this is really important. And in recent years, we know that the model has increased in popularity among clinicians and training institutions. Our um, our society has over 3,000 members across 5 continents, and in parallel, empirical research on the model has expanded also significantly. We know that the evidence has been growing, which is great, but we should actually think about what we want to study, not only if we have more papers and articles, but what we want to study. We also know right now that early maladaptive schemas, they do present stability and difficulty in changing their content. We all know that. And they are contextually dysfunctional. And we do have a lot of body of evidence that indicates that the early maladaptive schemas, they do play a relevant role in the development of severe psychopathologies. And they do play a role in maintaining the severity of those psychopathologies. And in a recent review of the quantitative evidence in schema therapy, uh, it was pointed out that there are a total of 704 studies in the schema therapy approach, and 20 of which are randomized control clinical trials. And that's an important number for us because we want to expand on that to really test the effectiveness of our model. Uh, it is important to point that out that this research was published in 2024. So the research, uh, so the review was until 2023. So there could have been a different changes in those numbers, but it's important for us to be aware of that. It is also important to highlight that the body of evidence for schema therapy is still recent and has been growing recently, which may mean that new data, uh, which may mean that new data impact the state of the approach in the face of several outcomes. So, in order for us to talk a little bit further about our model, we should think about it in the different psychopathologies that it has actually been researched. So we'll actually start talking about schema therapy and BPD, so borderline personality disorder. We do have 4 randomized controlled trials for this population. We have the Gisenblow in 2006, John Farrell's and collaborators in 2009, Nardar and colleagues in 2009, and Mohammed Zadeh in 2017. All those papers, they actually presented positive results for BPD as a whole. The one thing that myself and another colleague we actually reran Cochrane risk of bias tool for randomized control trial with the ROB2. So we did run risk of bias for those papers, and we actually have the overall rating that is actually not great, but we should say that schema therapy has a total of 20 randomized controlled trials. That is what that research from Penn and Jerry told us. We have around 73, if I'm not mistaken, randomized controlled trials for DBT for BPD. And if I'm not mistaken, there are only 2 of those randomized controlled trials that have a low risk of bias. So this is not to say that these papers are not good. It is just to say that there's a risk for the bias of the results, which is not to say that those papers are not good. They are good. They are actually really good papers, but there's a lack of some information, and there are a couple of things that make it a little bit hard uh, to pass that ROB2 scale. And all of the randomized controlled trials, they did point out to positive results for schema therapy in the research outcomes. We also had a series of case studies that also show positive results for BPD symptomatology when treated with schema therapy. And qualitative studies also point to the positive perception of patients to the psychotherapy model focus on schemas. And this is actually really interesting because when we think about effectiveness, we actually are looking to statistics. We are looking at this mean, this big mean. So there's not really one patient that is saying that, no, this is great, I love it, the model has actually really helped me. No, we are actually looking at outcomes. So we do have a baseline, and then we measure that throughout the treatment. And within that time, we then take a look at those results, and then we are able to say, no, this is effective or not. But the qualitative study is also important because it leads us to understand a little bit better about how the model is being perceived by the clients as a whole. So it is really interesting to know that they do point out to positive perception. And we do need to point out that schema therapy is the second line of treatment. It is the second line of treatment for BPD. Thus, we could already think about schema therapy for BPD when DBT does not work or is not an option for logistic reasons. So if we do not have a group of abilities, for example, we should also, like the lack of skill group, for example, we could also already be thinking about schema therapy as a whole. Also, if I do not have the clinical expertise for DBT and the client actually does want to keep therapy with me, then we can think about schema therapy. What do we know about schema therapy and other personality disorders? We do know that schema therapy is one of the few psychotherapy approaches that has had its effectiveness evaluated in personality disorders for narcissistic, antisocial, obsessive compulsive, and avoidant, for example, allowing for a therapeutic possibility to these demands. What do we know about the research as a whole? There's in those randomized controlled trials that we have, there's a grouping of multiple personality disorders in those studies. And this this can be interpreted in a multitude of ways. It could be a confirmation of the transdiagnostic characteristic of the model because schema therapy is a transdiagnostic model of treatment. We are not really focusing so much on the BPD as a whole. We're actually thinking about schemas and modes. So it could actually confirm that this transdiagnostic approach to modes and schemas actually is what assists the treatment of those personality disorders. It could also be interpreted as a methodological limitation that makes it difficult to interpret data. And that's actually true. It is a limitation. So it's not to say that it is bad, but it is to say that it is a limitation. And we should think further in the future to be able to isolate and have different randomized controlled trials for each of those personality disorders. And I know that this is asking a lot, but one can dream. And in my dream, we would have a lot of RCTs for NPD, for OCPG, and for all those the clinical demands that show up in our clinical rooms. And I know that it is a lot. And I know that the researchers, I'm a researcher myself, they are doing their best. But it is important to understand what we do know already and what we should strive for. All the studies with other personality disorders that were grouped together, they reported positive results for schema therapy treatment on measures of personality disorders, although the studies need to improve in their quality, especially we can talk a little bit about the grouping of personality disorders as a whole. Then we can talk a little bit about schema therapy and eating disorders. We do know that the first line of treatment for EDs is CBT, the model that Chris Fairburn developed, that is a transdiagnostic CBT approach for eating disorders. But we do have some systematic reviews that indicate little superiority of CBT over other psychotherapies. And a systematic review by Susan Simpson showed that the presence of personality disorder or traces of personality disorder, especially cluster C personality disorder or traces of it, impairs the treatment of individuals with eating disorders. So if you do have a personality disorder or traces of a personality disorder and comorbidity with eating disorder, that will impair and that will uh, most likely difficult, will make it more difficult for the clinician to have a better outcome with the client. So treatment that implements a focus on personality issues, they do have a greater effect on the outcome of treatment with eating disorders. We do have 4 empirical studies for eating disorders and a systematic review about it. We have 1 randomized controlled trial by McIntosh and collaborators in 2016, 1 non-randomized controlled trial by Ansari and colleagues in 2020, 1 pilot group study by Simpson, 1 case study by Simpson Slowly in 2011. And we do have a systematic review by Josh and colleagues in 2023. All 4 studies, they do vary significantly in sample size, the psychopathologies that were studied, and study design, which makes any sort of generalizability. So to generalize the results is really, really tough. There is a need for more studies given the limitations of the scope of research. However, even take into account the differences, the different methodologies. The systematic review by Joshua and colleagues, they do support the use of schema therapy for patients with eating disorders, especially for individuals with long-standing and severe eating disorders. We do have actually a systematic review that points out that if the client has not improved significantly in 12 sessions with CBT, we should actually start thinking about different ways of approaching that client. So there are a lot of clients that will not benefit from CBT, and then a lot of those clients, they do have personality disorders in comorbidity with eating disorders, and then we can also think about schema therapy. If we think about schema therapy and substance use disorder, we do have the model of schema therapy dual focus. And it is a 24-week treatment model that integrates the relapse prevention work of cognitive therapy for substance use disorder and schema therapy. We do have 5 studies for substance use disorders with comorbidity with personality disorders. And 2 of those studies are series of case studies. And the other 3 are randomized controlled trials for double focus schema therapy. We do have a more varied range of results in these studies because when we talk about BPD, other personality disorders, and eating disorders, all that I said to you was that the outcomes were good. The results that we got from those studies were good. And that's not the case for dual focus schema therapy. In 2 of the 3 randomized controlled trials, the result indicated significant improvement by the dual focus schema therapy when compared to the groups of counseling. But in the randomized control trial of 2011 by Ball and colleagues, it showed worse results for, sorry about the lack of translation here, for the dual focus schema therapy when compared to individual in counseling for substance use disorders. Since then, there has been a decrease in the publications of substance use disorder and schema therapy. But in 2017, Chris Lee and Arnold Arns, they did publish an editorial letter questioning the results about that paper and how the methodology and about the methodology, especially pointing out that there were a couple of points that were actually important to be raised about how that paper was written and how the results were evaluated. It is important to point that out that the sampling, and there was a huge dropout in that paper. Dropouts, they actually are an important point to be evaluated in randomized controlled trials, but that could also be a reason for why the result was what it was. Uh, if we talk about schema therapy and depressive disorders, we do know that CBT is a safe, effective, and the most studied model in its treatment. However, when compared to other approaches, CBT tends to have mixed results on its efficacy. Some patients do not achieve the expected improvements with CBT model, and we do know that the population with depressive disorders has higher rates of childhood trauma, and which has a possible relationship with early maladaptive schemas. The evidence indicates that early maladaptive schemas are related to the severity of depressive symptoms and may mediate the process of change in depressive symptoms. The results of the present studies of the present schema therapy studies, they do present an optimistic view for the application of the model for this population when other empirically consolidated models do not present the expected clinical improvements. So, what are we saying here? If CBT or other models like behavior activation are not performing well for a client, we could think about schema therapy for that client. And we do have 3 schema therapy studies that stand out in working with this population. We have the RCT by Carter and colleagues in 2013, the RCT from Kopbeck and colleagues for inpatients or in the clinics, and the study by Malo-Jones and colleagues, which is a case study series. The randomized control trial by Kopbeck that was published in 2024, they demonstrated a non-inferiority when schema therapy demonstrated a non-inferiority when compared to CBT in the treatment of patients with depression. And I would like to highlight that result because this is such an interesting way of addressing and assessing schema therapy, because a lot of times when we're doing a randomized controlled trial, we want to understand, is that model better than the other? But we actually, especially when we do have a lot of a huge body of evidence that a model like CBT is effective for depression, we should not necessarily be looking to see if schema therapy is better than CBT, but if it's good enough or as good as CBT. Because if it is as good as CBT, if CBT has not performed well for that client, we could already think about schema therapy as an alternative of treatment. So, schema therapy does represent a potentially a high potential for being used to the therapeutic repertoire for treating depression. Although there is a need for further studies to consolidate the findings and thus to have a clear indication of the model for depressed patients. When we think about trauma and anxiety disorders, we do know it is actually a similar case to depression in a way that trauma and anxiety related disorders, they do already have specific treatments with robust evidence of efficacy. We have like exposed prolonged exposure by FOA. We do have CBT for trauma. We do have a lot of those treatments, and we do have a lot of exposure treatments for anxiety related disorders. And some studies in cognitive therapy, they do report high rates of dropout. They are close to 40%. And of those that do continue with the treatment, 1/3 they do not show improvement with total fading of the symptomatology, or with the total decrease of that symptomatology. And systematic review found that schema therapy does have a potential as a possible psychotherapy approach for obsessive compulsive disorder, anxiety, and post-traumatic stress disorder. A common feature that was found in that systematic review was in the work with trauma and anxiety related disorders is the combination of the schema therapy approach with other treatment components of exposure therapies. So in all of those treatments, they included exposure components. So we do know a lot by research that exposure is really, really important for anxiety and trauma related uh, work. So, especially for those clients that do not improve with CBT or do have the high dropout rates, to have that aim of the therapeutic relationship that we do have in schema therapy with the limited reparenting and all those other components could actually play a big role in assisting the client to do the exposure and also understanding the early maladaptive schemas and modes that might be also playing a role in maintaining the symptomatology. So what are the future targets for research in schema therapy? There are a lot, and if I had all the money in the world, I would be promoting all those research. I hope that someone does that, and I hope that we are able to have all those research performed and done one day. So it is important to know that we do need to have more replicability in the body of evidence for schema therapy, especially in regards of the randomized controlled trials. We have few randomized controlled trials that were actually replicated. So that is something that we should be aiming on. There is also a need for more non-inferiority trials, especially with disorders that do already have a good empirically based treatments like DBT for BPD, like depression, like CBT for depression, like CBT for anxiety, studies like that. We do need more studies comparing schema therapy to the first line of treatment. We can take a look on the scope of evidence, the body of evidence for schema therapy for BPD. We only have one study that actually compares DBT and schema therapy. And that's actually really important because we do want to understand how it performs with the first line of treatment. So just adding here, most of the schema therapy randomized controlled trials do not compare schema therapy to the first line of treatment for the research disorder. We do need more multi-center studies. We do not know so well the role of culture in schema therapy so far because most, if not all, of the randomized controlled trials, they are performed in Europe. Most of the studies are done in Europe or the US. There are a couple of studies on the Middle East as well, but we do need more multi-center studies. Latin America, Africa, Oceania, all those places, they do need more trials as a whole. So there's also a need to test the underlying theoretical assumptions of the model. We do have a lot of uh, theoretical models that explain a lot of the psychological phenomena that we see in therapy, but we have not tested many of those. So we do not know exactly what is the role of reparenting. We have not been able to assess the role of reparenting. We do need to understand what are the mediated and moderated aspects of the therapeutic process in schema therapy. We need to know what and for whom uh, and how does that work in psychotherapy. We do need more in schema therapy, psychotherapy. We do also need more longitudinal studies to understand the development of early maladaptive schemas and how they perpetuate and consolidate themselves within each client. We do need that the protocols of and data from trials that they should be a little bit more open to decrease the risk of bias. This is a really important point when we think about the trials that we do already have. It can be a little bit tough to see those results and actually to assess it. So I know it is tough, but if we were able to take have those protocols published, that would assist a lot in the decrease of the bias of it all. Other populations should be studied regarding ethnicity, sexual orientation. Most of the studies are, like I said, was performed in European or US based individuals. So we should also think about LGBTQ patients. We should also be thinking about patients that are based in other parts of the world. And we do need more ideographic studies on schema therapy treatment. So we should focus more on the individual and understand also how the treatment works within that individual. That could also be a really important way to understand how the schema therapy treatment is working. And that would also leads us to a direction that is similar to what process-based cognitive behavioral therapy is doing as well. But we do need, there are a couple of points of attention that we should be aware of. For schema therapy and its theoretical consistency, for schema therapy and the measured outcomes, and schema therapy and its assessment tools. There are a lot of changes in the schema therapy that was once designed by Jeff Young and the ones that we do know now. Some of those changes are actually really aligned with the research that we have, but a couple of changes, they do not have the evidence to back that up. So we need to have a schema therapy that is theoretically consistent and is consistent with the evidence that we have. We should thinking about improving and updating it, but only when the evidence supports it. So it is important that we know that. Otherwise, we'll have a lot of different schema therapies. Is that a problem? Not really, but we should thinking about a coherent and consistent approach that is connected to the evidence that we have. We do need to be mindful of the measured outcomes that we use in the randomized controlled trials. In some of those, we might be looking more about schemas and less about clinical improvements as a whole. So this is an important thing to be aware of. And we do need better schema therapy tools, especially when we think about the YSQ, the SMI. There are evidence, there are a lot of evidence that can that leads us to understand that we need better assessment tools and easier assessment tools for our clients. So changes in theoretical and clinical in the clinical model should only be implemented when there's convincing and replicated evidence. This is something that we should be aware of, and we shouldn't change things if they have not been tested. We should test the model of 5 needs before we change that, for example. And then to end this presentation, another big physicist, Richard Feynman, and he says that I would rather have questions that can be answered than answers that can be questioned. So we should be always questioning what we know. Guys, it was a pleasure being here and talking from Brazil to all of you. I hope that it was at least somewhat insightful and that you got something from this presentation. Here is my correspondence, and please write to me if you want to discuss a little bit further about the evidence that was presented here. It was a pleasure, and I hope that you enjoy World Schema Therapy Day. Have a good one and big hugs from Brazil. Bye bye.